See, so yes, yes, thank you for the recording. I was just going to ask for that. We are thankful for each of you that are here and for those that are on the way. Let's see, one, two, three, four, five, six. Yeah, for those that are on the way. So it is March 26th. It is time for our monthly Sarcoma REACH event. I am Naglitha Johnson, co-founder and director of programs for Life Waters Ministries International, of which Sarcoma REACH is our flagship program. Let me just turn my phone off here. We have some board members here that are with us. We have some friends and family, some new friends. We have some members of the Sarcoma REACH advisory team that are here with us. And we are excited to have everyone. I will ask the co-founder and CEO and president, Jimmy Johnson, if he would just give us a wave and if there's anything you want to say before we get started.
Yes, good morning or good afternoon, good evening. It is a pleasure and thrill to see everybody again. Les, good to see you as always. Miss Margaret, Miss Sheila, Team Negletha all the way, Miss Sheila and Miss Margaret. So, it's good to see everybody. And glad to have Dr. Posey with us. And we're excited to hear all the great news and information he wants to share with the group. So thank you very much.
I thank you, Jimmy. I appreciate it. If I could get any, let's see, board members. Yes, you know what? Thank you, Patricia Williams, for putting in the chat your name and where you are with us from, where you currently are. If everybody would just do that, just go in the chat because we're going to be burning a hole in this chat soon. Put your name and where you are if you can. Obviously, if you're driving, we don't want you to do that. We don't want you to, be harmed. But if you're in a position where you can put in your name and where you are from, where you are currently, I guess is what I'm trying to say, that would be great. And we also have some of the members of our Sarcoma Reach advisory team. We have Melanie Davis with us, Takolia Reeves, who's also a board member, Sheila Bean, who's with us, Margaret Livermore. I don't know if Suna is with us, Suna Haley. I'm not sure if she's with us. Suna Halley. But we do have those amazing individuals, and we have Les that we were just talking with a minute ago, currently in the great state of North Carolina, was our very first presenter for our Sarcoma Reach events for 2025. Les and his beautiful wife, Sheila, did a wonderful job sharing with us about their journey with sarcoma cancer after Les's diagnosis last September. We also have Reginald Williams with us, who he's with us tonight, who was our presenter. He was our guest rather last month. Talked about, hey Reggie, shared with us just from a super heartfelt place about the journey with his daughter who was diagnosed with sarcoma cancer. So we are thankful for having our past guest with us. It really means a lot. We have, again, friends new and old who are with us, and we are very thankful. We're going to move on. Sarcoma Reach, for those of you that don't know, Sarcoma Reach is the flagship program initiative. It's our flagship initiative for Life Waters Ministries International. Life Waters Ministries is an almost 29-year-old Christian outreach. Our goal is to foster hope, healing, and restoration in individuals and communities around the world. Sarcoma Reach. REACH stands for Research, Education, Access, Cure, and Hope. Why are we focusing on Sarcoma Reach? Again, as I've shared for the last 2 months, when you have certain things that knock on your door, all of a sudden those things grab your attention. And sarcoma knocked on our door by way of my third oldest sister, Diane, who was diagnosed in 2015. with uterine leiomyosarcoma cancer. And she journeyed with that diagnosis for just 16 months. In May 29th of 2016, she went on to better places, to a better place rather. And so as a result, as a result, this became paramount for us. And so I believe that God used that as an opportunity to redirect the work that we have been doing. And so we are thankful to have this opportunity to even know about and to share about sarcoma cancer. You can find more information about Life Waters Ministries on our website. It's LW Ministries online.org. You can learn more about Sarcoma REACH at sarcomareach.org. Thank you for joining us, Sonia. It's good to see you. If you'd like to serve as a volunteer, I'm inviting our volunteer coordinator, Tacolia Reeves, to put in her information. Just put it right in the chat how folks can reach you if they need to. I also invite you to subscribe to our YouTube channel. Our YouTube channel name is Life Waters Ministries International, the nonprofit. And that way, by subscribing, you can stay abreast of all of the latest content that we upload there. The link for that, it will be in the chat. If it's not already in the chat, you should see it soon. And we encourage you to please subscribe and let's stay connected. With us this evening are all amazing people, and among those amazing people are some wonderful individuals who have had their own diagnosis with one of the over 100 subtypes of sarcoma cancer. And so we are thankful to have those individuals with us. We are thankful to have each of you with us. We are thankful for those who are with us who I know have also had any type of cancer or other types of cancer as well. Um, Last month, as I mentioned before, we had Reggie Williams with us. You can find his video, the video that we did on YouTube. You can also find the YouTube for Les from January. Um, both very informative, very heartfelt. And I encourage you to view those videos if you haven't already and to share them with other people. There's good information on those videos, whether the person has a sarcoma cancer diagnosis or any cancer diagnosis or just going through a challenging time. Those YouTube videos have some good information. Tonight, though, our topic is clinical trials and the Black community. Clinical trials and the Black community. I'm going to invite you to put your questions in the chat. We will probably more than likely address those questions at the end, but I will do my best to try to incorporate those questions throughout if I can. So, with us tonight, who will be bringing to us information based on his knowledge, his expertise, where his heart is Dr. James Posey. Please join me in welcoming Dr. James Posey. Dr. Posey, there you are, there you are, there you are. Here we are. We're sending love your way. Thank
Yeah,
you for being with us. Thank you for being with us.
well, it's indeed a pleasure to have the opportunity to be with you guys and to learn a little bit about what you're doing in the space of bringing living waters to people that they might live and not die, that they might
Absolutely.
triumph and have victory in this life as well as the next. So grateful for the to at least learn a little bit about the work that you guys do. I haven't done a deep dive, so it's a pleasure to meet you guys. I haven't,
Absolutely.
I'm not really into, I don't like to use the word trolling, but I did not look after our conversation. That
Yeah,
was probably the last time we've had a chance to connect until now. So it's a great pleasure, honor to be with you.
absolutely.
It's great to meet
Absolutely.
you. and your husband, Mr. Dr. Johnson. So, and then those of you that are a part of this great organization, it's a wonderful opportunity to have to share with you. I'm a medical oncologist by training. I've been in academic practice for over 20 some odd years, and started in the Deep South, moved back to the Mid-Atlantic area where I'm from, and we left academic practice to focus on a ministry direction, as well as from a medical oncology and cancer care perspective. I'm the president of the National Association of Black Oncologists, and we have some initiatives that we're rolling out, which I probably won't get into. But just in way of background, that a little bit about me. Um, I wanted to tonight talk about sarcoma, just the disease state, which I'm sure you guys perhaps have done this. But I also think it's a reasonable approach to look at clinical trials and why clinical trials are relevant, and how we can move the needle forward with respect to clinical trials. So then I'll talk a little bit about what I think is relevant about clinical trials.
Okay.
Um, and I'm hoping that no one takes away from my commentary about clinical trials that you think that I'm trying to encourage you to go on a clinical trial.
Mm.
But hopefully it provides some insight as to why they are relevant. So I think I have the capacity already to share my screen, so I'm going to do that if that's okay. Can you see my screen?
Yes, we can. Thank
Okay,
you.
good. Um, so we already talked about me. So soft tissue, I'm going to focus primarily on soft tissue sarcomas, but as
Okay.
you probably know, um, sarcoma can be divided into two entities. One, you have bone sarcoma, and then the other are the myriad of subtypes of soft tissue sarcoma. And so basically, sarcomas are a little bit different than carcinomas. I'm going to use a lot of these terminology, but a little different than carcinomas in the sense that the tissues that they're derived from are can be thought of as mesenchymal or connective tissue. So, um, whenever we think about a cancer, we always want to know, well, are there any signs and symptoms? And sarcomas are a little unusual in the sense that there aren't necessarily hallmark symptoms that scream this is a cancer. But as you may see here, a sarcoma may appear as a painless lump. And there are a lot of things that are benign, but if one were to have a painless lump, it would certainly be an indicator or something to bring to someone else's attention. Um, and that can be typically in an extremity. If now, obviously, bumping yourself can result in a lump, but this would be a lump that's sort of unprovoked, painful, doesn't go away, continues to increase in size. And then there are sarcomas that occur in soft tissues that can cause other symptoms, and we'll talk about one of those that I think is interesting as it pertains to clinical trials. So just in a way of sort of looking at sarcomas as a group of, this is with respect to soft tissue sarcomas, as a group of tumors, incidence and prevalence is important. Prevalence would suggest that people are diagnosed with it, but there's a lot of people that still have it that are alive. And incidence would certainly look at how frequently does this occur. And for 2025, you can see here the estimates. About under 15,000 cases. It's typically a male dominant tumor. And then here are the death rates. But when we think about incidence, this is, and I'll show on some other slides, it's not a real common malignancy or type of malignancy. we tend to think about this as being a tumor of soft tissue, most of them occurring in older patients, although there are populations of certain kinds of tumors that we see in the pediatric population, such as here on this slide. Rhabdomyosarcoma is commonly thought of as a pediatric tumor. It's not unheard of in an adult, but it's usually seen in a younger person. Whereas what I heard mentioned on more than one occasion, leiomyosarcoma is one of the more common diagnoses, along with liposarcoma in adults. And so there's a male predominance, actually, except for when you're dealing with parts that men don't have. Okay, so and then when we think about the most common risk factor, these are the things, and you'll see this on more than one slide. This is where testing needs to be performed to look at risk factors that might prevail in a family, for instance. And so we think about Lee-Fermani, neurofibromatosis type 1, and Gardner syndrome. And the reason we think about those is because if the person that has the tumor, that particular type of tumor, were to test positive, there's a higher likelihood that family members could also be carrying the gene that can increase the risk of sarcoma, as well as about 4 other types of cancers that I'm not going to talk about tonight. So when we think about the epidemiology of this, or the 5-year survival, if one were diagnosed with this tumor, you can see that number there. And it does vary by location. So soft tissue sarcomas of the extremity typically have a better prognosis, but there are some variables that impact prognosis. But children generally do a little bit better than adults when diagnosed with any sarcoma. So I alluded to earlier about genetic risk, and for instance, if there's a genetic alteration as listed on the previous slide, the risk of developing a tumor is 6 times higher than the general population. But there are environmental factors that are worth being mindful. And I don't know if in this case, if a viral disease is an environmental factor or more of a lifestyle factor, but with respect to radiation exposure, so women who've been diagnosed, say, for instance, with breast cancer and have had radiation on that particular side, there's a slightly higher risk of developing a sarcoma as a consequence of radiation. And the radiation exposure risk is oftentimes related to the dose of radiation, and usually there's some other subsequent trauma. I think actually the more important thing to think about are, and this isn't, a guarantee, but chemical carcinogens. I want to say this about that. And I love the title of the ministry. Think about it this way: are you getting enough living water? And what's in your living waters that can offset the troubling things that we living around in our environment? So we need a certain amount of living water. So what are we putting in ourselves? So you got two factors there. What are we putting in our spirit being, and then what are we putting in our natural being that can offset some of the impact of herbicides, dioxin, and there's another chemical that I'll comment on in another slide. So I just wanted to highlight here 2 things on the slide, or 3. That the second point, that when you think about the age standardized incidence rate, this type of tumor seems to prevail in a little bit higher incidence in North America and in other countries in higher socioeconomic class. The lowest rates are observed in Latin America, Japan, and Korea. And generally speaking, globally, it's not a very common tumor. There is some variation between 2 to 5 cases per 100,000 people. Um, so this and here, when we think about the median age, it's around 62 years, and it seems to increase. So 51% of the cases are occurring in patients over the age of 61. Again, that's not to suggest that it couldn't occur in a younger person, but when we think about soft tissue sarcomas, they're primarily tumor of older adults, and then that drops off after around like age 75 for whatever reason. So how do we diagnose a soft tissue sarcoma? Um, Gold standard here is MRI, and magnetic resonance imaging is the best tool that we currently have for being able to make a distinction between soft tissue and bone and to be able to discriminate between the two. X-rays are essentially good for air and bone, but would not have the discrimination, and even CT has some limitations. So MRI is considered gold standard. Um, the second point here, the biopsy, at that point, um, I'm gonna suggest that this needs to be some of this work should be carried out in a higher quality medical centers. Sarcomas are probably the one group of tumors as a whole where you're thinking multimodal care, surgeon, possibly a medical oncologist, possibly a radiation oncologist, and as a consequence, kind of like prostate cancer, there's a lot of special care that goes into the management. And then before we even get to the pathology, of course, the biopsy has to be done in the right place under the right conditions so that you avoid the risk of seeding, which is a big deal with sarcomas of the extremity. And then, of course, having a pathologist that's experienced enough to be able to characterize what's being observed carefully is important. Just a few words about therapies and without any specificity here. So localized disease is what we would think of as being a opportunity to eradicate the cancer and have a person eventually go on and live their life without cancer. But typically in the extremity setting, again, this is where the multi-specialty intervention is comes in. A surgeon, not just we don't want the root canal surgeon playing around down here with the extremity. So this is high quality surgery, and someone that's expert in these areas is clearly what's necessary. The last point here, this drug doxorubicin has been around for about 45 years. It's probably most useful in breast cancer. It's been used in sarcomas. It's not the greatest medicine in sarcoma, unfortunately. And that's often why clinical trials emerge as an option, typically with sarcomas in the advanced setting very early, or they should emerge as a option very early. And we're going to talk about that. Sure. So in terms of just special considerations for sarcomas at whole, and then I want to focus on two other types of sarcomas in a moment here. But in general, sarcomas require specialized centers for care, I believe. And most of them, or at least half of them, occur in extremities. And so there's an opportunity, if the tumor has not spread, to eradicate it and hopefully not have it be a problem again. Interestingly, late diagnoses are observed in underserved populations, and the outcomes are not as good. And then the other thing that is notable here is the survival is largely related to whether it's advanced or not and how it's characterized. So the tumor grade becomes important. I think these are more technical details that are important, but to me, emphasized the necessity to be at a facility where these things are sort of, they're known. They're not, it's not a nuance, it's a known, this is a known definite thing that we need to achieve. So leiomyosarcoma, and I'll talk about it. This first slide just has some general commentary about leiomyosarcoma. Remember, we said that it's a, under the microscope, a lot of soft tissue sarcomas are considered leiomyosarcoma. And then you have specifically the uterine leiomyosarcoma. So it's not, again, a real common tumor. The median age is similar or close to what we saw with just general sarcomas, around 60. But here, fairly low incidence, even in among women for uterine leiomyosarcoma. Higher incidence in white folks relative to Black or Latina, although Black women have a higher incidence of fibromatosis or fibromatous neoplasms. And this is not just of the uterus, but in general. So what does that mean? So most women have heard about fibroids occurring in the uterus, and those are benign. Fibromatous neoplasms are different, and that's why if there's any concern about a fibroid, there should be some further characterization of that, particularly if it changes in size. But I can delve into that more if need be. But in terms of this other distinctions ethnically, Latina males have a higher incidence of liposarcomas. So liposarcoma is a malignant tumor of some people say, well, that's just a fatty tumor. And fatty tumors can occur in different parts of the body, the extremities, the neck, the different places. It is kind of important to have those evaluated. And then here, in terms of, we mentioned this earlier that, well, we alluded to it. Black patients have a slightly lower survival with sarcoma compared to Caucasian patients. And this is felt largely to do with stage of diagnosis and where patients are getting their care. We mentioned risk factors. Again, phenoxyl acids are things that can be found in anybody do any gardening, herbicides and pesticides and things of that sort. In prior radiation exposure, we talked about lead-for-mania, which is probably the most common genetic syndrome, which can increase the risk of colon cancer, breast cancer, and a few others, as well as sarcoma. But here, special considerations are just the overlap and the distinction between a fibroid and a fibromatous malignancy, and making sure that the appropriate evaluation is done. It's not good enough to not have the appropriate evaluation for, particularly in the uterus. Yes, we need to make sure we're seeing a GYN person and that they're carrying out the right evaluation and characterizing it well. Otherwise, questions. Here, when we look at access, for instance, with sarcomas, leiomyosarcoma being the most commonly diagnosed histologically, or what it looks like under the microscope, both outside and within the uterus, we do see an outcome between metropolitan care and rural care. And that largely has to do with, again, places that are likely to have expertise in being able to manage a tumor that's arising in a soft tissue. And then advanced stage diagnosis are unfortunately more common in underserved populations. So I want to switch gears to a tumor that when I started my career there, we didn't know much about this. We thought it was an uncommon tumor. It was occasionally mistaken for a leiomyosarcoma, and some pathologists say no, this is a gastrointestinal stromal tumor. Has anybody heard of that? I don't. In gastrointestinal stromal tumor or GIST. So the reason I think it's important to talk about is because I started my career not that long ago, but it was long ago. And just the amount of information that has reshaped this tumor is tremendous and has resulted in some significant improvement in outcomes in this tumor. So for instance, here we say that the annual case is about 4,000 to 6,000 a year. When I started my career, we thought that there were around 2,000 a year. And so some of them were, now probably better class. So there's better classification of the tumor type. There's better evaluation of it under the microscope. It's still not very common in the United States and Western Europe. Again, this is a tumor of typically older adults. We generally don't see this in younger patients. Although you can see it in those that are in their 20s. I've seen a few young people with this. So it does happen, but it's uncommon. Now, if you like reading the slides, you're going to read a bunch of things on this slide that aren't going to make much sense, and I'm not going to explain them. But look at it, because now people are saying, oh, let me read, what is he talking about? Thank you, I appreciate it. So this is what really changed the dynamic for gastrointestinal stromal tumor as a soft tissue sarcoma now, that we thought was uncommon, is the fact that someone was focused on developing a drug for another disease. It was called chronic myelogenous leukemia, or CML. And so in drug design synergy, for what happened as a consequence of that is the drug turned out to work and it turns out that CML and gastrointestinal stromal tumors share a common defect in a pathway that results in the cancer. I'm going to characterize it this way. We know that sarcomas, some of them, I asked if anybody did any gardening, and has anybody ever spliced anything into a, like, no, I'm not seeing any, for the faces I can see, I ain't seeing any movement. But if you were to graft, imagine grafting a branch. Some of you done this with indoor plants where you stuck it in some water and you let it sprout, and then all of a sudden you got yourself a new plant. So if you can think about that, that's how some of these tumors actually originate, is parts of the growing part of a normal cell combines to a growing part of another normal cell, and all of a sudden you end up with what we call a fusion protein. And it turns out that somebody was very interested in developing a drug that would target CML, and it turns out it worked beautifully in GIST because of this fusion protein, or a similarity in how the drug worked for a fusion protein. And I'm going to characterize it like this, and this would not be a good idea, by the way, because most of you probably lock your door when you go home, right? If you're by, you lock your door, right? So imagine you have a key, and someone else also has a key. Their key was for their house. Your key is for your house, but it turns out that there's some cross reactivity between your key and their key, so that they can get in your house too. So that's what happened with this tumor. It turns out the drug was being developed for one tumor, and it turned out that it worked for this rare tumor that no one really knew much about, because after all, there was only 2,000 cases a year. So this is a comparison between non-GIST and GIST. These tumors are generally found in the GI tract, whereas we mentioned that other sarcomas are of connective tissues of the muscle, like the tendons, ligaments, fat. And there are some drivers. Molecular drivers is what we're talking about here, but I was trying to characterize it another way with a key and a lock. Turns out that driver are these two things, KIT, but we later found out about this. So it turns out that this drug has a 5-year survival that's typically much longer, and you can achieve that oftentimes either by taking a pill, and nowadays, 20 something years later from when this was kind of discovered, when I was getting started, there's like 6 or 7 or 8 different pills that are used to treat this particular type of soft tissue sarcoma. Now, what that involved was it involved a lot of analysis of this type of tumor under the microscope, which meant what? Somebody had to get a biopsy. And sometimes those biopsies were done inconveniently to understand what we now understand about this tumor. So I'm going to show you this. So I know, well, some of you might be in science class and like science class. This is not for that purpose. What I'm trying to show you is what we've learned, or what's been learned about the alterations in GIST over the course of 20 years, to the point where there are multiple drugs that are now used to treat this particular type of sarcoma very effectively. How did that come about? Somebody was on a clinical trial. Somebody got a biopsy. Somebody's tumor was characterized to find out what happened. And I'm gonna summarize it to say this. So these variations that you see here in color, I don't know if you can see my arrow, but these variations you see in color are alterations that occur. So think about it this way. You have a lock to your house, right? And you have a key that fits that lock. The key is the drug. And when you take that drug and you put it in the lock, it's the same way that of taking a drug that fits the alteration in the tumor. So when that drug fits the alteration in the tumor, it actually shuts the tumor down. It turns the tumor off. It tells the tumor, you're not supposed to be growing. In fact, you need to die. Quite a remarkable type of therapy, right? But what can happen over time is, like other tumors, the key, for whatever reason, no longer fits in the lock. Turns out that what's been discovered are these multiple alterations that can occur either over time, or sometimes they're determined de novo, so that the key never did fit in the lock. So it kind of be like someone messing with your lock and changing some of the, what do you call that, the little pins, so that the key no longer works effectively. So how do we learn all this? Clinical trials. Over 20 years, drugs been developed to target these various alterations. And so the course of this disease process has changed. I'm going to skip this slide. So that more often than not, we know what results in a more aggressive tumor. Some of the same things as for general sarcoma. Size is important. So, greater than 5 centimeters versus 2 centimeters. And then how actively the cells are dividing. These are the things that determine how aggressive it's going to be. But the point is that there's 1, 2, 3, there's at least 5 lines of therapy for a tumor that was felt to be rare, because of a discovery, and because people that were diagnosed with this participated in clinical trials, and we understand a little bit more now how to treat a tumor that's far less common actually than some of the other ones that we still struggle with. I'll leave this one on. That's a scientific slide there. Clinical trials. What's in it for me? That's usually the first thing so I don't know how many have heard about clinical trials or thought about participating in a clinical trial, or ever asked to participate in a clinical trial. But from the standpoint of clinical trials, I think that becomes a hallmark, and that should be something you should ask, or if a clinical trial was ever presented. So I want to comment on a little bit on clinical trials, or a lot on clinical trials. So clinical trials can be divided into preclinical and clinical. So if we're thinking clinical, that's what are we doing for the patient? Preclinical are studies that are done in the laboratory, and that's or in animal models to determine if something looks promising. So typically, there are 3 phases of a clinical trial. The first phase is often the principal focus of a first phase, or what we sometimes will call a first in human, is this drug looks very exciting in an animal model in a laboratory for doing what we needed to do in a person with a malignancy. But at the same time, we don't have any experience with it with a person with a malignancy. And so the first thing that becomes relevant is safety. Is it safe? Do people tolerate it? Does it cause some unfavorable side effect? And then the other thing that's usually sought is how well is it handled in the body? And this is usually done in small groups of people, so maybe 30, 40 people. Oftentimes, one may hear about a phase 2 trial. A phase 2 trial I think of as proof of concept or proof of principle. So the drug, we know kind of what dose to use for most cancers. We've demonstrated that it's relatively safe, or we know what the spectrum of side effects are. They're manageable. More importantly, most important thing about a side effect, it's reversible, right? No one wants to have an irreversible side effect, right? Now, having said that, some things can happen that are not reversible, but they can become, then that's where you balance if I lost my hearing, but the intervention was effective against the cancer, which is life-threatening, that's something one has to consider. But typically we like to think that a side effect's reversible in time, or we're stopping the medicine. And then in a phase 3, you're generally saying, okay, this medicine looks promising for a particular disease. It might be a specific type of soft tissue sarcoma. Where there's a big struggle is liposarcoma, and well, some of the other histologies as well, leiomyosarcoma. But the drugs in those arenas are not that great. So phase 2, phase 3 might come up very early after an initial intervention if surgery is not the only option. But in a phase 3, you're usually comparing a new drug plus standard of care, or compared to standard of care. Just general concepts, large number of patients. And the thing that oftentimes is scary, so you have a treatment, these are treatment trials now. In addition to the treatment, some studies, particularly in sarcoma, may involve a tissue sample. And the tissue sample may be secondary to participating in the study, or it could be primary to participating in the study. What do we mean? We're saying, well, you can't participate in the study if you don't agree to a biopsy of the spot 2 weeks after you started the medicine. Or you could, but it's voluntary. And in both those instances, it probably comes down to how altruistic the person is. We'll get to that. We'll talk about that now, another moment, in a minute here. And then, so these are the 3 basic levels of clinical trials. So when you hear phase 3, or maybe you don't, if someone was ever talking to you about it, the concept, the drug is probably a little bit further along than phase 1, if it's the first time in a human being. So I talked about this a bit, but from a phase 1 standpoint, or it could be first in human, it may not be. This may be a first in that specific type of cancer. Again, the principal thing is generally safety. It's a smaller size trial. The risk, as listed there with the red X, is it may not be clear what all the known side effects are. They'll read some things that we know from the consent, and typically it's everything because we don't really it's not really clear. So when you look at a bottle of has anybody ever experienced ringing of the ears from aspirin or developed a nasal polyp from aspirin, GI bleed from aspirin? So aspirin has a list of side effects, but most of it, some people pop them pretty regular for one thing or another. But in a clinical trial, you're gonna see a whole list. In a phase 2, I think it's just worth jumping to the red X here. The 66% fail here is not really referring to the patient. This is referring to the fact that a lot of the drugs that are evaluated appear promising, but they don't go on to become a therapeutic that's used in the clinic with a drug name manufactured by some pharma company. I'd like to think that the efforts to find new therapies, effective therapies, was, maybe at 50, maybe it was the other way around. The 60% of them are effective, and 40% of them don't quite make it on to the next level. And then in a phase 3, usually I'm gonna point at the green benefits. Usually there's enough data to suggest this drug's probably doing something. It's doing at least as much as standard of care. The question is it far superior to standard of care? And oftentimes, if it reaches a phase 3 level, there are probably some regulatory considerations, meaning this drug is likely or could maybe get approved for use as a drug in the near future for this same entity. Now, I'm gonna put one caveat out here, and that's in the very first line. This is I hate this, and I usually navigate for my patients in this regard. Is the placebo necessary? And this is something that it should be very clear for persons ever participating in the study. Am I getting a placebo, or does the study involve a placebo? Now, let me make that distinction. As a patient, you may not know if you're getting the placebo, but you should know if you were enrolled on a study, is it a placebo-controlled trial? Meaning, is there a component of this that's hit or miss? I may not even be getting the new therapy. Some of those studies have what's called a crossover, that it's unblinded 2 weeks in, 4 weeks in, and then you can maybe get the novel medicine. But that's an important aspect. Typically, we see with phase 3s, but sometimes now even randomized phase 2. This last slide here is clinical trials across the board, 1, 2, 3. Among the participation typically in clinical trials is low. It's lower for us, African Americans. And we stand to benefit from a clinical trial, but sometimes that benefit may be what's learned from me may help somebody who looks like me. And that's why oftentimes, and I think I had on the first slide here, that clinical trials, the first thing we have to think about is altruism. Where does my head fit? And that's one of the things our group is developing, or one of the things we want to look at is, as National Association of Black Oncologists, is to try to recharacterize a scale. There's a few scales that are out there measuring selflessness versus selfishness. What's in it for me versus, hey, I might be able to help someone else. Now, having said that, the earlier the phase of the trial, the less likely most people are to be completely altruistic. I'm doing this with no benefit to me, but it might help somebody else. Um, and then there are other things that people have measured that factor into how altruistic a person is. But sometimes you find that it has nothing to do with socioeconomics, education, things of that sort. It's really where that person is with respect to what's going on with them and how they're addressing the fight in a cancer. I'm going to stop with that. I hope I didn't talk too long. I see a hand on the chin. I don't know if that's a good thing or a bad thing.
It's all good. It is all good.
Okay.
It is all good. It is all
Okay. Okay.
Yeah. I want to kick off with a couple of questions
Sure.
and invite others to do the same. Um, I probably have at least 30 questions, but not tonight, right? Um, so let's see. A couple of things. You said that participation in clinical trials for African Americans is usually low. Okay. Do you have a sense of why that is the case? Um, why so? One of the things that I think I mentioned to you when you and I were talking, I think on the phone, was when I've mentioned clinical trials to folks, one of the things that come up many times is are those trials, those federally funded research studies from years back where Black folks maybe weren't treated as well, like the Tuskegee experiment and other kinds of things. And so, we don't forget those things, and so we go into things like kind of clinical trials, kind of wondering, you know, how am I gonna fare? Um, Added to, we don't always know the right questions to ask. Um, so it often feels, I know I got this is these about five questions woven into one. So pick whichever one. And so we often feel that we sometimes start out at a disadvantage because we don't necessarily know the questions to ask. For example, when you mentioned about I think we're talking about leiomyosarcoma and uterine leiomyo. If the GYN starts talking about fibroids, as a Black woman, do I just stop there? Yeah, there was a time, but there was a time I would have stopped there because I didn't know that there were other questions that I should have asked. And I just use my sister as an example. I wish I could have encouraged her to ask other questions because her doctor swore up and down. She just had fibroids on steroids. That was my description because she had many and they were large. But there was never any concern that this could have been something beyond just your regular another Black woman with fibroids. So it's all of those pieces, and I think all of those kind of factor in my mind to the difficulty when we look at clinical trials and and the Black community, that may point to why our participation in these trials are lower compared to other groups. So
No, you raise very significant issues relative to participation in clinical trials. So I'll say this. I think there's a number of reasons why participation is low. On our side of the fence, on the provider side of the fence, oftentimes participation is impacted by um, the time that is needed to explain why a clinical trial may be of importance. And it's not just one of the things when I'm talking with training physicians, it's not what you say, it's how you say it in some cases. In other cases, um, the patient has already gotten a sense of whether they think what you're telling them is not reliable, not the truth, not scientific, but is it something that, do you feel me? And the answer is, it may be that you didn't get a good feeling. And so you left out of the office with a diagnosis, weren't really sure. You're like, hey, look, maybe we'll just go with the standard therapy. I'm not sure why this clinical trial. And so on the provider side, there's reasons why. Not enough time, didn't connect with the patient properly, didn't explain what the pros and cons were in a way that's tangible for the patient. On the and then in some cases, we know, and there's data that's been published, that patients aren't presented clinical trials in some cases, and that could be a factor, or they're told that they're not a candidate and
Mm,
they're not really told why. So
mm.
there's a multiplicity of reasons, and that's an area where I think in the field we hope to do better. That's one of the focal points of our group, in fact.
Understand. Patricia mentioned in the chat, she says, I participated in a clinical trial once on heart health at NIH, and they asked me to recommend other Black women. So it was by word of mouth. She says, I guess as a trust factor. Um,
Yeah,
okay.
I mean that's something that depending on where one is and where they're receiving their care, uh, oh, again, it's a dynamic that the feeling is if the person you're engaging with as your healthcare provider doesn't understand some of the dynamics of your community, they
Mm,
may feel that if they've engaged with you, then you might be able to engage with others in your community and break and help to bridge that barrier that exists. It's a thing that's well discussed in our arena called implicit bias. I didn't
yes.
say anything. It's just my body language
Yeah.
told me all I needed to know. I don't feel like that person was feeling me when I was talking to him, and I didn't get a good feeling.
Understand. 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 I have another question, but I want to just see, does anybody have anything they want to unmute and pose a question before I ask mine? I don't want to dominate with all of my questions. Anybody, let's see. Can I, okay, Jimmy, and then I want to read what Margaret has. Yes, sir.
You can go ahead and read what Margaret has.
Okay. All right. Margaret Livermore says, I find it stressful that there are gynecology oncologists that have never heard of uterine leiomyosarcoma. How does Dr. Posey think we can spread awareness in this demographic?
Are we referring to among GYN oncologists?
Uh,
Yes. Oh,
Yes, yes, GYN oncologist.
I mean, I certainly probably wouldn't follow up with the GYN oncologist that's never heard of a leiomyosarcoma. That's kind of like, you know, saying you play professional basketball and don't know who Michael Jordan is. I mean, that's not, I mean, maybe 100 years from now, somebody might not know who Michael Jordan is, but you know,
Yeah,
it's
but
kind of hard not to understand that there are sarcomas of any sort that can arise in the uterus. And if that's your area of focus, that's the kind of thing that's germane to that region. I don't know that there's a way to, I don't know that, for instance, I wouldn't be the first one to say, hey, do you know that to talk to a GYN oncologist? I would
mm,
like to think that that's uncommon.
mm.
I hope so. But I've
Yeah.
had two people who have met with GYN oncologists who did not know of the cancer, and both of them have that cancer.
They may not have ever treated it. I don't know. That's a hard one to really understand because it's way too germane to the practice for a GYN oncologist, GYN. Now, an obstetrician, even that would be a little uncommon, but I mean, if you're delivering babies, you're not treating the cancer, so you probably aren't uh, dealing with it as much. So I just don't think that that would be a little unusual. to me.
All right. Yeah. Thank you, Margaret. Jimmy
Quick question.
Johnson. Okay.
First, let me say, Dr. Posey, I am Nagleetha's husband, and she's the real doctor in the family. I just, my service was just in the military for a few years, and so we're together. But well, let me first by said you are probably the only doctor I know that was been able to communicate this scientific information in a way that's digestible without, with some understanding. I was
Mm.
able to write relevant questions that, from my perspective, that were interesting to me. So, thank you for your presentation, and you just appear to be able to read the audience and the needs right away. So, to that end, my question centers around, you said late diagnosis in undeserved population kind of worsens the outcome. To that end, I'm 65 right now, 66. If something happens, what can I say? And I ask this question from the perspective, reach, research, sarcoma reach for us is research, education, access, cure, and hope. How can I give, offer hope to someone in an undeserved community,
Underserved. Yeah, underserved.
underserved,
Okay.
underserved community,
Yeah.
and they're at a late age. They don't know how long they'll live. Why would they choose a clinical trial? Get back to Margaret's question. They might have gone to the doctor, and the trust is not there. So what's the hope for them to keep living, and pursue and seek out professionals like yourself? Maybe that's I don't know. That's a philosopher question, but I'm just thinking from old country boy from North Carolina. How would I convince the people in the country? Come on, please listen to what we're saying. Make sense?
Yeah, it does. I think the challenge is really the first part. What is you we're actually the last part of your reach acronym. What is your hope in?
Mm, mm, mm,
Without hope, the heart grows sad, right? Word of God tells us that. So what is your hope in first? Some people may lose the will to want to fight, want to pursue, and that's not something you can fix with a anecdotal answer. I think, um, so it largely, but for someone who is interested in pursuing, they want a opportunity to experience maybe a better outcome. You know, so it's not going to be for everybody, but for those that will hear what you have to say, those are the people that you're trying to reach. I mean, we're in the same trajectory. Um, our organization is reaching into communities to try to sound the alarm, to try to have faces and voices that are ones that can be more readily related to talk about how we can help. But not everybody's going to want to receive that.
Fair comment. I mean, that's fair.
All right, thank you, Jimmy. Here's another question. What are the factors this is from Tacolia Reeves. What are the factors that determine the 5-year survival rate?
I think Brother Johnson, if I can call you that, was talking a little bit about that late stage of presentation.
Mm,
It's
mm,
late stage of presentation. And certain tumors are just more aggressive under the microscope. They appear to be more aggressive. Um, those are the probable size is the other. So size, aggressiveness, and late stage of presentation are the principal things that affect survival, 5-year survival, 2, 3-year survival, in fact.
Okay. Another question from me, and if anybody else has a question, please jump in. Um, and I think you might have mentioned this earlier on, but if you could just share with us again, at what point after diagnosis should the discussion regarding clinical trials even come up? Um, my thinking had been that it's just later, when everything else has been tried, so to speak, and now we've done all of the normal therapies and we've done those things. Now let's try this. So were you saying earlier that is something that the doctor should in that the patient should engage in a conversation with the doctor early on? So at what point should this discussion about clinical trials come up?
Yeah, so great, good question. I think clinical trials, well, it depends on where one's getting their therapy. So typically a clinical trial is not going to happen in the community, in the office setting where an evaluation may have been initiated. Clinical trials are usually going to be carried out at either an academic center or some sort of tertiary care facility that has access to clinical trials. And it's at that point that one may find that for the state, either the histology, the type of tumor, what it looks like under the microscope, or the stage, that there could be a trial that's asking a question. And sometimes it may be the first therapy for an extremity sarcoma. And the question has to do with the type of radiation or how the radiation is delivered. So it's not a major deviation from what would be routine. But the question is does this new form of radiation impact a cancer where cure is still the goal? But it's a trial that's looking at a novel form of radiation, for instance. So it's really site dependent in terms of who has access to what kinds of trials.
Hmm. All right. Any other questions before we move on? Any other questions? Any other
I
questions?
see one question here
Oh, I'm
about
sorry.
cost of clinical trials. I'm gonna speed up a little bit because
Uh,
I gotta jump onto a meeting
yeah, no
in about
problem.
10 minutes. But
Yes.
are the cost of clinical trials free? The answer is no. Um, but they should not necessarily cost the participant anything other than standard of care. So typically when we design a trial, we're billing to the insurance company those things that are considered standard of care. So if you're going for an office visit every 3 weeks, that's standard of care. If there's any specialty blood, specialty labs, specialty uh, imaging that's part of the clinical trial, that should be covered by the clinical trial. Now, having said that, some people will say, well, I'm going to call my insurance company. That's probably something that may not be the wisest thing to do because insurance companies don't want to pay,
Mm,
but they'll pay for the things that are considered standard. And the way trials are typically, and this it's a good question to raise with a provider. The clinical trial should cover the cost of those things that are not standard of care, but it's not free, so to speak.
mm, okay. Mm, okay. Um, which brings up another question that I want to ask because I know we don't have time. But so we will stop there. And I'll share a couple of things, and then I'm going to ask one other really quick thing from you, Dr. Posey, that I'm sure you won't mind doing. But before that, we do want to thank Dr. Posey for being with us. Yes, Jimmy, I'm in agreement with you. You shared many things that we could take in. You know what I mean? You
Good.
presented it in a way that was understandable, relatable. So we're thankful for that and thankful for your time. We're thankful for each person who is here with us. Our next Sarcoma Reach event will be April 23rd, and the hope is actually to do a part two of the discussion that we started tonight. I think there's some additional information and some additional conversation around this that I think would be helpful. So with that, Dr. Posey, I'm looking at your bio here that you sent, and one of the first things you have under your name is pastor of Greater Love Fellowship Church. Yes. Yes, okay. And so we are thankful for that part of your life. And if you would be so kind, would you mind closing us out in prayer? Just covering the people that are here. We have many people that are with us that are going through many things, either physically or you name it. Lots of things going on. So we'd be honored just to have you to close us out in prayer if you would.
Be glad to.
Thank you.
Thank you for the opportunity, and we'll pray. Dear
Absolutely.
gracious Father, we thank you for your loving kindness. Father, I thank you for the benefits that you have loaded us, your people, with on today. Father, I pray for these, Lord God, that are on the call. Father, that they would recognize that you are the source of hope, not just eternally, but you said that you came to give us life and life more abundantly. So, Father, we thank you for that which you have given us in the earth realm. I pray, Lord God, you would strengthen those on the call that need strength. I thank you for sending ministering angels to those that need a physical touch. I thank you for moving in their bodies. I thank you for meeting their needs, that they would recognize that you are indeed the true and the living God, the uncontestable, eternal, immortal, omnipotent God, and that you love, Lord God, your children. So I thank you for your blessings flowing toward them even now in the mighty name of Jesus. I pray. Amen.
Amen. Thank you so
Thank
much.
you.
All right. God bless you.
Bless
And
you guys. Good night.
absolutely take care.
All righty. Bye-bye.
All right. Bye bye.